Today we are going to start with the autologous blood transfusion. So what is the meaning of autologous blood transfusion? Yes, can anyone tell me what is the meaning of autologous blood transfusion? Yes, what is the meaning of autologous blood transfusion? It means usually in the usual condition, we are collecting blood from one donor and then we are infusing the blood to a separate recipient. So the donor and the recipient is different in usual kind of blood transfusion. But in case of autologous blood transfusion, the patient's blood is collected and is reinfused back subsequently when it is required. Okay. So over here, I am taking the blood sample from the same person, and after a period of time, I am returning it back to the same person. Okay. So this is called as autologous blood transfusion. Okay. Autologous, that is to self. Okay. Is it clear? So now you must be thinking that what are the advantages of autologous blood transfusion? Why is it that we have to carry out autologous blood transfusion? So first very important thing is there, it avoids the transmission of infection. So the chance of infection from another person is not there because the same blood from one person is going back to the same person. So the risk of transmission is considerably gone. Okay. Number two, very important thing is it is avoiding immunological complications. So whatever immunological complications or adverse reactions of blood transfusion that we had seen, that was because of antigen antibody reaction. For example, the hemolysis or because of TRALI or graft versus host disease. So all this immunological complication is there because antigen of one person is binding with antibodies from another person. Yes, that was the problem. But over here, the second person is not involved. The same person is there. So it is avoiding any kind of immunological complication whatsoever. It is also reducing the need for blood from the donors. So for example, if considerable amount of individuals, they can pre-store their blood in their local blood bank, then it reduces the need for extra amount of blood. Is this point clear? It is avoiding the need for any extra amount of blood. So always remember this point very importantly. It is going to reduce the need for blood from the donors, and it creates less pressure on the blood bank. Okay. Very important in those individuals where finding compatible blood is very important or very difficult. For example, people who are having rare blood group, for example, that is your Bombay blood group. So in these individuals where finding another individual with a Bombay group becomes difficult, so it is very safe that a person can go and pre-donate the blood and store the blood in the blood banks. Okay. Or patients who have developed multiple antibodies against the red cell antigens. Okay. So what is going to happen? Any blood you are giving to the patient, it is not compatible. Okay. There is a compatibility issue. So that person with so many antibodies against the RBCs, they can have their own blood. Okay. So that individual can have their own blood with lesser reaction. So these are the advantages of autologous blood transfusion. Okay. Now we are going to see there are three important methods of autologous blood transfusion. One is your pre-deposit autologous blood transfusion. That means before any surgery or any anticipated blood loss, I am going to pre-deposit the blood in the blood bank. Okay. Second is your acute normovolemic hemodilution. Here, we are going to intentionally dilute out the blood either during the surgery. Okay, that is intraoperative normovolemic. Just before surgery, I am going to dilute the blood. Okay, I am going to tell you what it is. And lastly is the blood salvage. So whatever blood is lost in the operative field during intraoperative or during post-operative period, whatever blood is collecting in the drainage bag, that is being filtered clean and given back to the patient. That is what is the blood salvage. Is this point clear? Let us begin first with the pre-deposit autologous blood transfusion. Now, this is basically indicated in case of elective surgery. Okay, it is indicated in case of elective surgery. So, for example, some elective surgery is there where a significant blood loss is anticipated. For example, a patient is pregnant and she wants to have a cesarean section. Okay. And for example, we are anticipating at least 1 liter blood loss. Okay. In that surgery. Okay, or for example, there are some other complications also, okay, that we are anticipating. Some twin pregnancy is there, or some complication is there, and we want to go for the Caesar. So in those kinds of elective surgery where significant blood loss is anticipated, or for example, in case of how should I say, in case of total knee replacement surgery or cardiac surgeries where more amount of blood loss is indicated. Okay, so in those situations, we are going to in elective. Elective means that it is planned, that the doctor has planned that in so and so date of next month or next week, I am going to do the operation. Okay, so the basic thing over here is that the patient's blood is collected before the surgery. How much time before surgery? Around 5 weeks before surgery, the patient's blood sample is collected. That patient blood sample that was collected is again stored in the blood bank. Because where are you? Because if you are collecting 1 month before the surgery, 5 weeks before surgery, you're collecting the blood. Okay, so in that situation, you have to keep the blood in the blood bank. And when the date comes after the surgery is performed or during the time of surgery, the blood is going to be reinfused to the patient. It is back reinfused to the patient. Okay, so just remember this particular point, that over here the blood bank is playing a role. So what is the importance? Why am I saying that blood bank, when it is playing a role, we are storing the blood? So the risk of clerical error is still there because the blood is being stored. So again, clerical error can occur. Okay, so that is why when we are storing the blood in the blood bank, some of the complications is still there. I will discuss about it later on also. The collection for this type of pre-deposit autologous blood transfusion is beginning 5 weeks before surgery. And why? What is the idea of 5 weeks before surgery? Now, for example, this is the first week. Okay, so blood is collected on first week. Then the next unit of blood will be collected in the second week. So blood is collected after every 7 days to allow the time for formation of the blood. And remember that maximum, how many units can be collected? Maximum 4 units of blood will be collected. So first week, second week, third week, and fourth week. So in the third week, you will collect one blood. In the fourth week, you are going to collect one blood. So every week after 7 days, you are collecting. And then in the fifth week, you have the surgery. So you are giving at least 7 days, or we are giving a required amount of 7 days. At least 4 days should be there before surgery, but we are keeping the safe margin of 7 days before surgery. So maximum 4 units of blood can be collected in this manner, and last collection should be there at least 4 days before the scheduled surgery is there. Is this point clear to everyone? When the collection is starting? Yes. How the process is being collected and how much unit and till when and in which interval the blood is collected. Okay. Now during this period, the patient is also put on oral iron supplements as well. Now blood bag is properly labeled and it is sent to the blood bank, and it is again before issue, very important, because we are sending the sample, the patient's blood, to the blood bank. So before you issue or before it is reissued, all the pre-transfusion testing is done. That is, you are going to do the ABO blood grouping, RH typing will be there. After that, cross matching will be performed. Okay, and then after minor and major cross match and all the required elements are fulfilled. Okay, then the blood is going to be issued. So this step is going to remain same in the pre-deposit variety of autologous blood transfusion. This is very same as the homologous type of blood transfusion that we have seen before. Now, patients with rare blood group, okay, patients who are having very rare blood group, yes, for example, they have the Bombay blood group. Okay, here the patient's RBC is stored in the blood bank. They are frozen, maybe at -60 or -65 degrees centigrade. They can be stored for approximately 10 years of time. Okay, so they are frozen and they can be frozen for many years. Okay, so those individuals with a very rare blood group or who have developed multiple antibodies against the RBC antigens, okay, in these individuals we can store the blood for many years. Okay, in this manner. Is this point very clear? The idea of pre-deposit autologous blood transfusion? Yes, everyone. Any doubts in with regards to pre-deposit autologous blood transfusion? Yes. Okay. If you don't have any doubt, then I'm going to go for what are the contraindications for the same. So if the patient is quite debilitated, is suffering from some kind of a cancer, or there is the significant cardiovascular disease or severe anemia, or the patient is has any kind of trauma and he already has lost blood, or it is a traumatic thing that is there, or uncontrolled hypertension, diabetes, epileptic patients, or pregnant patients. So in these individuals who are hemocompromised, in these individuals, you should avoid this pre-deposit autologous blood transfusion. Now, patients with bacteremia, if the patient is having some kind of blood infection, if you suspect the patient is febrile, okay, at the first week of taking the blood, the patient is febrile, you should defer it. Why? What is the reason? If the patient is having fever, we should not go for this autologous blood transfusion. What is the reason? We are going to give it to the same patient. Then what is the problem? Yes. Suppose you have collected the blood, okay, on the first. And on the first day, the blood sample was containing, for example, 10 units of bacteria, for example. Now, by the fifth week, when you have to, when you have to give the patient back the blood, okay, on the fifth week, when you have to give the patient back the blood, this amount of bacteria is going to multiply. This amount of bacteria is going to multiply and become 1000. And when this blood sample is given back to the patient, now this sample is containing so much cytokine, so much of bacterial products that it might lead to shock. It might lead to shock and the patient might die on the table after you transfuse this blood. Is this very clear? If the patient is bacteremic or having fever, you have to, you should preclude the patient from autologous blood transfusion. Is this point clear to everyone? Yes. Kindly just mute everyone. Now, patients who are having any kind of transmissible infection. So, for example, the patient is an HIV positive patient. Okay. So now you people tell me the patient is HIV. We will take the blood sample from the patient and we will give it back to the patient. Then what is why we are not, why it is a contraindication for pre-transfusion autologous blood transfusion? Yes, can anyone tell me? Yes. See, you are understanding, right? Basically, what is happening over here, that basically the patient's own blood is being stored in the blood bank, and at the time or after surgery, it is being transfused. Now I'm asking you, the patient is HIV or hepatitis or any infection is positive in the patient. Now, why am I not giving, why do I preclude such patients? Why am I precluding such patients? Yes, why it is contraindicated to do autologous transmission? Because over here, it's a very simple common sense answer. See, this blood will be stored in the blood bank. Yes, and this will be given back to the patient. But at the blood bank, there still remains the chance of clerical error. Yes or no? So this HIV positive blood of the same patient can by mistake be issued to some other patient by mistake. Okay, and as a result, it might lead to the spread of infection. So it is better not to go for autologous blood transfusion of individuals who are positive for HIV or hepatitis. Is this point very clear to everyone? Yes?
Yes, sir.
Okay. Now you must be thinking that we are already screening, but I will tell you, in most of the HIV and in most of the hepatitis patients that we are coming across in today's world, you know what is the biggest factor for the transmission of such infections today? In AIDS, it is not the sexual transmission which is common. In today's age, AIDS is being transmitted because of the faulty blood, because the patient's blood was collected during the what should I say, during the window period. Even hepatitis. So maximum patients now with hepatitis and AIDS, although the incidence has come down, it is because of this blood transfusion that they have. So it is very much important to preclude such patients who are having such infection. So these were the contraindications of the pre-deposit autologous blood transfusion and also autologous blood transfusion as a whole. Now, disadvantage, what are the disadvantage? Okay, what are the we have read about the advantage of the autologous. So what are the disadvantage? First of all, if, for example, now the surgery of the patient that was scheduled is now cancelled because of any reason, surgery was cancelled. So whatever blood was collected, it will be wasted. Why it will be wasted? The reason is because when we are taking the blood from the same person and has to be given to the same person, then the strict donor criteria is not maintained. We don't take the proper history. we don't take, all the relevant history. So that blood is not suitable to give to any other person and has to be thrown out. Okay. Also, if for example the blood was used, but if for example some blood is left, for example I collected 4 packets or 4 units of blood was collected, okay, and only 1 unit was used, then 3 unit has to be thrown out. So in that situation there is a wastage that is occurring with autologous. Okay. Second thing is, it cannot prevent the risk of circulatory overload. The risk is there. Now this adverse effect of blood transfer, this risk is always there. The risk of clerical error is there because it is going to the blood bank again coming back, so risk is there. And the risk of bacterial contamination, now this contamination can occur when you are harvesting the blood, when you're taking or collecting the blood. Yes, so bacterial contamination risk is again there. So these risk factors or these disadvantages are very similar to the homologous blood transfusion that we had done before. And for this, now normally if you want to go and voluntarily donate blood, so you will go to the blood bank and you will donate voluntarily. Yes, so there is no such planning and organization that is required. But over here, some kind of planning and organization is required between the patient, doctor, as well as the blood bank. Okay. So is this very clear about the pre-deposit autologous blood transfusion, the disadvantages, contraindications, the process, when, where, how we are doing this process? Yes. Is it very clear to everyone? Is it clear? Okay.
Yes, sir.
Can we move ahead? Okay. So now the second type. So the first type was that there was some surgery, and before the surgery, I had made the arrangement of the blood from the patient party. The blood collected from the patient party was given from the patient is given to the patient itself. Okay. Now the second thing over here, what we are doing, it is happening immediately before surgery. This process is taking place. See, the term is acute normovolumic hemodilution. So what I am trying over here, I am not overloading the patient with the blood. I will be maintaining the normal volume. Say for example, I will be maintaining 5 liters of blood only. In usual, for example, in 5 liters, for example, there is 4 to 5.5 million RBCs. Okay. But I am going to create a situation wherein just 2 to 3 million RBC will be there in the same amount of blood. Okay, understand, this is what situation I am going to create, or the doctors is going to create. So immediately before surgery, the patient's whole blood, 1 or 2 units of whole blood is collected. Okay, so for example, understand that 1 liter of blood or 7 to 800 ml of blood is collected from the patient. Now, whatever 800 ml of blood that is being collected before surgery, that is being replaced. Okay, how we are replacing that with either a crystalloid or with a colloid. So in case a crystalloid is replaced, then 3 ml crystalloid is given for any 1 ml of blood. And in case colloid is used, then 1 ml of colloid is replacing 1 ml of sample. So for example, as 800 ml of blood is being taken out from the patient, then approximately 2400 ml of crystalloid will be given. Or if a colloid is being replaced, then exact amount, equal amount of 800 ml of colloid will be replaced to the patient. Okay, is this very clear to everyone? So basically the idea over here is what, that the surgeon or the doctor is basically trying to create artificially, he wants to create normovolumic hemodilution. That means he wants to create the same volume of blood, but with less amount of RBC. So what is the advantage over here? So see, I told you, normally a person is having 5 liters. Now, if this person is losing blood, for example, say 1 liter he is losing blood, then he might lose 1 to 1.5 million RBCs. Okay. But over here in this case, where I have already created a normovolumic situation, but a hemodilution is created. So if 1 liter blood is being lost, so over here only 500,000 RBCs will be lost. Understand? A 0.5 million RBC will be lost. Is this clear to everyone? This concept is clear? Acute normovolumic hemodilution. Yes. Is it clear? Okay. So over here, what we are doing, we are creating a hemodilution to reduce the red cell which is lost for a given amount of bleeding. For the same amount of bleeding, less amount of RBC will be lost if we are pre-surgery, we are collecting the RBCs. Okay. So what is happening over here? The blood collected from the patient is kept in the OT room. Okay. And it is kept near the patient. It is not sent to the blood bank. So the risk of clerical error is going to go down significantly. And even the blood is stored at the room temperature because the surgery will go on for 1 or 1.5 or 2 hours. So it is a very short period of time. Okay, so it is within 6 hours. So there is no significant loss of clotting factors or the platelets. Okay. Now, very important over here, therefore, because the blood sample is being kept in the OT room, testing, so ABO grouping, cross matching again is not required. Okay, it is not required. It is carried out if more than 1 liter or more than 20% blood loss is anticipated. Now, what is one very important contraindication? If the patient is having a cardiopulmonary disease, if the heart or the lung is compromised, it cannot tolerate the hemodilution that we are going to give. Okay, so careful monitoring is essential for all such patients going for acute normovolemic hemodilution. Is this point clear to everyone? Acute normovolemic hemodilution. Any doubt anyone is having? Now, the third important thing that we are going to see over here is blood salvage. Now, what is the blood salvage? Over here, there's a collection of the blood that is shed either during surgery, which we call it as intraoperative blood salvage, or following after surgery, if there is blood leakage, that is called as post-operative blood salvage. First, to understand what is the meaning of salvage. Salvage is to, to prevent any further loss. That is what is called as salvaging. Okay, so blood salvage means to protect any further blood loss. Okay. So we are collecting the blood, whatever blood that is shed during the surgery or post-operative, and subsequently we are reinfusing that particular blood sample, that recovered blood, to the same patient. That is what is called as the blood salvage, which is the third important type of autologous blood transfusion. So in any case of elective or emergency surgery, when the blood loss is extensive, for example, total knee replacement or trauma, cardiac surgery, or ruptured spleen or ectopic pregnancy. So in any kind of elective or even in emergency surgery, we can do this. So remember over here that the procedure is contraindicated if the salvaged blood is contaminated with any bowel contents, urine, bacteria, or any amniotic fluid. Bowel contents over here means any kind of fecal material if it has contaminated, okay, or any urine content has contaminated that blood, then that blood will not be reused because 100% there will be infection. Now, the reinfusion, whatever blood that was salvaged or collected, should be reinfused back within 6 hours, because after 6 hours, what is going to happen that the RBC will lyse, there will be release of potassium, hyperkalemia will be there, and the risk of bacteremia is also there when there is a prolonged storage of blood. So let us see, in case of intraoperative surgeries, the blood salvage, the blood aspirated from the operative field, okay, it is anticoagulated, it is added in an anticoagulation solution, and then that blood is filtrated. Okay, it is undergoing filtration to remove any kind of clots and debris. Okay, and then this particular sample that is filtered is again centrifuged and washed and suspended in normal saline. So the RBC or the blood sample is completely cleared of any dust or any bad particles, cleaned, washed, and then it is reinfused back to the patient. Is this clear how it is done, blood salvage? Now, what is the disadvantage of this process? It requires expensive automated blood salvage device, all the filter units, all the centrifugation units you need. So all this can become very costly affair for the patients. Okay, so you need a very costly disposable materials. Now, post-op surgery, post-operative surgery, when it is done, okay, means in case of post-operative blood salvage, whatever blood is recovered in the wound drains after the surgery, the patient is in the ward, whatever blood is collected in the wound drains, it is reinfused back directly through a filter. Okay, is this clear? This is about our autologous blood transfusion. So with this, we have completed autologous blood transfusion. Any doubt anyone is having regarding the autologous blood transfusion? This is a very, very important exam question. It's a competency given in the National Medical Council. Okay,